right, let's get right into it. Welcome to this high-yield explainer, designed to absolutely guarantee your mastery of Dr. Hoda Mohammed's guidelines on managing wear dentition. Whether you're gearing up for your boards or you just want a truly bulletproof clinical review, you are entirely in the right place. We're going to distill this incredibly complex topic down to the absolute most testable, essential facts so you can walk into your exam and your clinic with total confidence. Here is our quick roadmap for today. We'll start with classifying wear in OVD, then diagnosis and compensated wear, determining restoration necessity, core principles of occlusion, the diagnostic wax-up, and finally, execution and final restoration. Let's jump in. Starting with Section 1, classifying wear in OVD. Okay, you absolutely must memorize the Turner and Massillon classification. It's crucial because it dictates all of your space management later on. It breaks down into 3 very specific categories. Category 1, excessive wear with a definite loss of OVD. Category 2, excessive wear where OVD is somehow maintained, and luckily you have available space. And then Category 3, which is definitely the trickiest, excessive wear without loss of OVD but with severely limited space available. When you're evaluating severe wear chairside, you're not just looking at short teeth. You are actively hunting for where the restorative space actually went and checking whether that vertical dimension has completely collapsed. Keep this clinical picture burned in your mind as we move on to talk about diagnosis. Moving right along to Section 2, diagnosis and compensated wear. For any board assessment, remember that diagnosis is never just slapping a label on a patient's chart. It is a strict, multi-step clinical requirement. It's about accurately identifying the condition, pinpointing the exact etiology, establishing a solid baseline so you can frequently monitor them to prevent further degradation, and finally, actually formulating a plan to treat and restore what's already damaged. Because let's face it, you can't just fix the enamel, you've got to fix the root cause. And that etiology almost always points straight to a destructive habit like bruxism. Think about it. If you ignore the grinding, those beautiful new restorations are going to be destroyed just as fast as their natural teeth were. Identifying that etiology on day 1 is an absolute mandate. Highlight this next distinction in your notes because it is highly testable. Non-compensated versus compensated wear. Non-compensated wear gives you breathing room, specifically a freeway space greater than 4 millimeters. It's way easier to manage. Compensated wear, on the other hand, means the teeth have passively erupted as they wore down. That destroys your freeway space and severely limits your options. Always remember the 4 millimeter rule. Next up, Section 3, determining restoration necessity. You can't just pick up a handpiece the second you see wear. You have to explicitly justify your restorative intervention. The guidelines require you to filter your clinical decision through 3 precise questions. First, is this restoration actually necessary to control the patient's sensitivity? Second, is it required to satisfy their aesthetic desires? And third, based on their rate of wear, is it relatively certain that restorations will eventually be required anyway? If you hit a yes, it's time to act. When a case of severe anterior wear sits in your chair, running through those exact 3 criteria is what protects both you and the patient. This isn't just about making teeth look pretty, right? It's about systematically addressing pathology. If you answer yes to sensitivity, compromised aesthetics, or inevitable future failure, you are completely justified and totally exam-ready to proceed. All right, Section 4, core principles of occlusion. If you only take one single rule away from this entire explanator, it absolutely has to be this exact quote. Your primary goal in restoring worn dentition is establishing equal intensity contacts on all teeth in a verifiable centric relation. Verifiable is the magic word here. You must have a reproducible, healthy joint position before you even think about building up the bites. Beyond that, you've got to lock in 3 mechanical absolutes. Number 1, anterior guidance in total harmony with normal functional jaw movements. 2, immediate disclusion of all posterior contacts the exact second the mandible moves away from centric relation. And 3, anywhere that punches completely through the enamel layer and into the dentin, that has to be restored, period. Moving right to Section 5, the diagnostic wax-up. Now, physically doing a wax-up is one thing, but knowing how to critically evaluate it, that's what separates a novice from a true master. To ace this topic, you need to know the 4 critical diagnostic questions used to evaluate the success of your wax-up before a burr ever touches a patient's tooth. Run every single wax-up through this specific matrix. 1. Can the lower incisor edges be correctly contoured? 2.
Is there a definite, solid holding stop for each lower incisor edge against the upper lingual surface? 3. Can you correct the upper incisors without interfering with the neutral zone and the patient's lip closure path? And 4. Is your anterior guidance perfectly established between your centric stops and upper edges? At this point, you're at a crossroads. Your specific planification has to be driven by your overarching treatment goals. The diagnostic wax-up literally forces you to choose between distinct clinical paths to actually achieve the results you mapped out.
Those established goals we just talked about are going to push you down one of 3 main avenues. You'll either figure out that you just need to reshape the anterior teeth, or you might realize you need surgical crown lengthening to physically gain restorative space, or, and this is a big one, you will methodically plan to increase the occlusal vertical dimension. And finally, Section 6, Execution and Final Restoration. You have to memorize this exact clinical progression, and please do not skip steps. Step 1, always start with the diagnostic wax-up on mounted casts. Step 2, proceed to reversible methods first, specifically an interim occlusal splint. This reduces symptoms, normalizes function, and lets you test drive your new OVD. Only when that patient is perfectly comfortable and stable do you move to Step 3. Prepare the teeth, place provisionals, and finalize the anterior guidance directly in the mouth. So the final crowns are seated. You're done, right? Actually, no. Because patients with a history of severe wear will almost instinctively press and brux against any new restricting anterior surfaces. You have to protect your work. You are clinically required to prescribe a nighttime appliance. It needs to be a full occlusal splint featuring centric relation contact on all teeth, plus a built-in ramp for posterior disclusion. And that brings us to one last vital reminder. You must clearly communicate the severe consequences of these noxious habits to your patient. Because ultimately, having the most perfect, board-ready restorative technique in the world won't matter at all if you send a patient home just to grind it all away. So, when you look back at these strict guidelines, ask yourself, will you be the clinician who just fixes the teeth, or the one who actually stops the cycle of wear?